Hello, everyone. Welcome to another virtual morning report. Today, we are super excited. We are going to have another POCUS session, and we have a really special guest. Is Dr. Prager. He's an internist and intensivist practicing London, Ontario, Canada. He's a critical care ultrasound research, and we are super happy that he accepted our invitation today. Ross, do you want to say hello for everyone?
Yeah, thank you. Just thank you for having me. I'm looking forward to talking about this case and ultrasound. And I imagine, or I hope that this is just the start of the discussion and we can continue it on Twitter. And I know that you guys are very active on Twitter. So hopefully this leads to more discussion and learning coming forward. So thank you guys for having me.
Amazing. And we like to ask our guests, like, what do you like to do outside of medicine? Something for fun.
Ooh, outside of medicine. So me and my partner, we rock climb. So that's something that we like doing together. And yeah, so I guess that's my fun thing. In the winter here, it's indoor climbing, but yeah, it's something great in Canada that we have lots of rock climbing. So and skiing in the winter, I guess. But there's not too much skiing out in London, Ontario. Only cross country. So the downhill skiing was more in medical school when I was meant to be in classes. So yeah.
Amazing. Yeah, I think we can start with the presentation.
All right. So thanks everyone for having me. Again, here's my X handle. Now it's no longer a Twitter handle, but feel free to message me if you have questions related to the talk, and I'm happy to share resources and whatnot. I was just going to ask, is somebody going to be admitting the people that are joining the waiting room here? Yeah, good.
Yeah, we
All
can do
right.
that.
So I don't have any relevant disclosures, but as this slide clearly indicates, there's a long-standing history of POCUS going back to the medieval times, and also that generative AI is a thing. So disclaimer that many of my random graphics are generated by generative AI and may not make sense, as you will see shortly, but this is a medieval oil painting of the early POCUS practitioners. So just in terms of a little bit of background about myself, so I practice in London, Ontario, which this is a map of Canada slash the US, and here's Toronto, here's Detroit, and in between is a lovely town called London, Ontario. It's about 400, 500,000 people, and it has two main kind of hospital systems, but the main university that we have is Western University, and the reason why I bring this up is many people on this call are going to be from around the world, and we're really lucky that we celebrate having international fellows and residents and trainees come to learn at our institution. And I think that's something that really adds a lot of learning for us and just creates a really rich culture of excellence. And so hopefully one of you on this call hears this and reaches out and finds a fellowship or a training program here, and we would love to have you. So and specifically, we also have a critical care ultrasound program with fellows from around the world. So feel free to reach out to me and I'm happy to connect you with that. So my clinical practice is in critical care. I have another disclosure. I'm not a real internist anymore and I don't do any internal medicine practice, but part of my practice is critical care ultrasound. And at our institution, we're really lucky to have an acute care internal medicine POCUS service, emergency medicine POCUS service, and critical care ultrasound POCUS service at both hospitals at all times. And so we can essentially do ultrasound on all of our patients whenever we want, even when we're really busy. And that's really thanks to the gentleman holding the TEE probe on the right of the screen, Dr. Arnfield, who's been sort of one of my mentors and one of the leads in critical care ultrasound for Canada and North America. So certainly I wouldn't be where I am without acknowledging his role in that. So thank you for that. So admittedly, I'd never heard of Virtual Morning Report and hadn't listened before this invitation. So I went and picked up or listened to one of the things. And oh God, there was like ceruloplasmins and ACE levels and things that I hadn't thought about in years, to be entirely honest. And so I think I feel a little bit like an imposter here from an internal medicine perspective. So I'm going to really focus on the core part of this case for me, which is the point of care ultrasound. So my only advice for the clinical problem solvers here is that when you hear hoofbeats, think horses, because I really don't know the zebras that you guys would be talking about. So this is nothing fancy and nothing exciting. The case flow as I envision it is I'm going to present a little bit of history, and then there will be an opportunity to kind of for you guys to ask questions, fill in the gap. I'll make you commit to some of your kind of differential diagnoses as they're going. We'll go through some physical, some basic investigations, and then commit to sort of initial management. And then after we've committed to initial management, there will be some sort of clinical conundrum that happens with this patient. And hopefully we can find how POCUS can help us solve that a little bit. So with that, so this is Mr. HF. He's a 73-year-old gentleman presenting to the hospital with 2 weeks of fatigue, abdominal distension, dyspnea, and some leg swelling. He's maybe has a little bit of orthopnea, but there's no PND at all, no infectious symptoms, no chest pains. He has a history of heart failure, preserved ejection fraction, and the upper reports down there with a normal EF, severely dilated RV with moderate systolic dysfunction, and mild TR with an elevated RVSP. He's on some kind of poor heart failure medications here, but some Lasix, some Spiro, apixaban for his AFib, and not allergic to anything. Here is his ultrasound here, so we can see that he has a severely dilated RV. Can you see my mouse? Yeah. So he has a severely dilated RV up here. LV function appears grossly normal, a dilated right atrium here if we're going to look at that. But essentially, what we'd call HFpEF, because technically the ejection fraction is preserved, but we know that HFpEF is a grab bag for many different diagnoses, including pulmonary hypertension and primary RV dysfunction. Socially, there's really nothing remarkable in the social history. He lives at home with his wife, and then there's no family history that is relevant. So at this point, I know that was probably the fastest history ever taken by an internist, but that's normally what I ask. So I kind of welcome any questions about history. What do we need to kind of figure out what's going on with this patient? And I'm happy to kind of highlight the history that we have so far.
Well, I think since Maddie and I will be discussing, do you want to start, Maddie, or should I do it?
Go for it, yes.
Okay, so in this patient, he comes with fatigue, abdominal distension, dyspnea, leg swelling. Fatigue can be a somewhat broad differential. Dyspnea, we are very familiar with the 2 + 2 + 4 schema. Now, leg swelling and abdominal distension makes me think of fluid overload. Before going to abdominal distension, I will tackle first leg swelling, which we can put like in 3 buckets that are according to what we can be thinking about it. So what I will be asking about the leg swelling would be if it's unilateral, bilateral, before continuing.
Yeah, bilateral leg swelling.
Okay, good. Because when we're talking about lower extremity edema, we can put this in like a Venn diagram. What can cause unilateral leg swelling would be something acute like cellulitis, DVT, a neuropathy, foot drop, etc. But in bilateral leg swelling, we can think of something more systemic. One of the main, the first place would be heart failure, pulmonary hypertension. We can also think if this patient may have also, or maybe he has nephrotic syndrome, whereas, or even malnutrition, where a protein loss can cause a increase in oncotic pressure, and the body keeps like getting this fluid overload. So if this is bilateral, I will put myself into something systemic, or even there is something that can cause both unilateral and bilateral. These are like 4 diseases that could be lipedema, lymphedema, malignancy, and CVI. Chronic venous insufficiency. But in this case, I will situate myself more into a systemic issue. So obviously, then we will like add more according to the history, the next aliquots. But for beginners, my workup would be maybe TTE, CMP, maybe a urinalysis, TSH, BNP, CPC, but that will be like further ahead. What do you think, Maddie?
Yeah, Yasmin, I love that. I love how you kind of summarize this so far. So very similar to you, I'm looking at this as a 73-year-old man who has a past medical history of known HFpEF, heart failure with preserved ejection fraction, who's now presenting with these 2 weeks, it seems like, of abdominal distension, leg swelling, and dyspnea. So, I think some reflex things, just common things being common, heart failure exacerbations are very common, and you can think there are some things that are pointing to this that could be consistent with that. So the leg swelling the mild orthopnea. We would expect some paroxysmal nocturnal dyspnea, but that doesn't completely rule it out. And we have learned from prior POCUS VMRs that POCUS can be helpful. So maybe we're not on the exam, we'd be looking for jugular venous distension. Maybe we can use an ultrasound to measure the diameter of that. We could also use the POCUS to look for B lines to see if there's pulmonary edema. So I think just kind of my reflex thought was common things being common. This patient has a history of heart failure. Is this a heart failure exacerbation? But another thing that came to mind was the abdominal distension. And I love, in VMR, we've talked about the phases of matter approach. So is the abdominal distension a solid, liquid, or gas? So the solid is this adiposity, or more rarely like organomegaly, the solid that's causing this distension. Is it liquid? So is it ascites, or more rarely is this like a hemoperitoneum? Or is this actually, in terms of the liquid, is this actually urinary retention? And that's kind of another use of POCUS. Maybe we could just quickly do a bladder scan and see if this patient is retaining, and that's the reason why the patient is distended. So that's solid, liquid, gas. Gas is this, is there some kind of ileus or obstruction? And I think that could be another use for POCUS. Just put on the ultrasound to see is this gas, is this liquid? So I think because of the POCUS VMR, the things that we could do quickly is look at the jugular venous distension, put it on the belly to see if this is urinary retention or gas or liquid, and then for the dyspnea and potential heart failure concern, see if there are some B lines. That's my thought.
Perfect. Well, I'll give you a bit more information just to keep it going. We'll go on to the examination, but just on kind of history. So this gentleman was at home, and unfortunately, due to some financial constraints, ran out of his medications and was waiting for some money to get his medication. So he hasn't actually taken any of his medications in 2 weeks, and his medications were kind of listed here. He says, you know what, I've had this once before, and it was when I stopped taking my medications last time, I got really swollen again, and my belly got really swollen. His heart doctor said it was something related to this Lasix or this water pill he was on, something like that is what he kind of says. He has not had any asymmetric swelling. There's no redness, there's no tenderness to suggest DVT or cellulitis. He says he's been voiding well. It's not particularly frothy. It's not particularly different in terms of his normal kind of urinary symptoms. GI-wise, he's eating well. He feels like he's well nutrished. His wife cooks for him. So hopefully that kind of clarifies some of your differential that you were alluding to with the etiologies of edema there. All right, well, let's go on then to physical examination. Oh, actually, not quite yet. So this is great. This is what DALI 3 came up with for differential diagnosis with POCUS. This clinician scanning the ultrasound machine, which is apparently pregnant. But kind of setting aside this silliness, what would be your top 3 differential diagnoses for this patient at this point, if you had to commit prior to physical exam and with no more information?
Congestive heart failure will be like on my top differential, pulmonary hypertension, and any kidney dysfunction. Although congestive heart failure can evolve to kidney dysfunction, but that will be my top 2 DDX. I'm not sure about the third one. What about you, Maddie?
Yeah, I'm right there with you. I think a heart failure exacerbation could be on the differential. I really like the pulmonary hypertension you mentioned, especially with the previous echo. I'm forgetting how long ago it was with the right ventricle dilation. And then not entirely sure how this is related. I'm concerned for potentially urinary retention given the abdominal distension we're seeing. So that's what I'm thinking.
I'm just going to probably add to that, consider the pericardium. Any ideas like what change in the pericardium could limit filling? Think about capacity to fill and increase diastolic pressure.
So if there's like a constrictive pericarditis, maybe, but I would maybe something that could point to that if there was like a preceding viral illness as one of the many causes of pericarditis, but maybe like constrictive pericarditis.
Awesome. Yes. So if there's a fusion, now you got fluid in the belly. So what if there's fluid around the heart? So it can pericardial effusion could also be causing right-sided features. This patient's having a lot of right-sided features.
Yeah.
And you correctly alluded, what if there's new myocardial injury? So ACS, myocarditis, maybe this patient has preserved ejection fraction. What if they have now reduced ejection fraction? So new injury to the myocardium could also present like this as well. So the couple of things I just want to add it, but I'll swing it back to Ross.
No, I think that's a great point. And so I think we often think about congestive heart failure as a very kind of, so we sometimes put that down as a diagnosis, but really we know that that's a collection of right heart failure, left heart failure, mixed heart failure, etiologies driven by pulmonary hypertension, acute glomerular disease, ACS. And so I like that we're kind of thinking about that because that may be relevant later down the case here. All right, so examination wise, their vitals pretty much normal. They have a bit of an irregular heart rate, but kind of otherwise they're just on a little bit of oxygen, maybe 1 liter. Alert oriented, they have a normal neurologic exam. The heart sounds, if you still have a stethoscope around, are normal. They have normal cap refill, irregular pulse, pitting edema to the knees, kind of looking like this. Their chest is clear, totally clear. They're in no distress at all. And their abdomen slightly distended, but there's non-tender. You can do what's the tapping thing, the fluid wave or the fluid shift or percussing dullness, all that stuff is all negative. What else would you want on physical exam? Is there anything in particular here that you want to know specifically to round out your exam?
Yeah, for me it would be, I will look for jugular venous distension, acute small sign, if there are any hepatosplenomegaly, and also if during auscultation, maybe if there is any gallops and the pulses alternans, because those are not remember how specific they are, but they could orient us to chronic heart failure or like heart failure or exacerbation or chronic. What do you think, Maddie?
Yeah, I'm right there with you, Yasmin. I think because we had talked about like heart failure and especially elevated right-sided filling pressure, I'd be curious about jugular venous distension. And you know, I know we're not. This is not high on the differential, but just for bilateral edema and for volume overload, the 3 systems I always think about are the heart, the liver, the kidney. So I would just want to make sure that there's no history of cirrhosis, no signs of like pulmonary erythema or spinal angiomas on exam, just to you know, put that concern lower.
Yeah, I'll just
Excellent.
add to that. Sometimes you can, as part of the physical exam that we teach in medical school, so percussion of the heart borders to determine if there's cardiomegaly. And then the second thing would be maybe checking for pulsus paradoxicus. And I see there an irregular pulse. So that's kind of interesting. That opens the door. Could this just be a sinus arrhythmia? Could this be actually an arrhythmia? So something like atrial fibrillation comes to mind. So you probably will want to get an EKG. And then in the history, there was no atrial fibrillation. If that is the case, then why is the patient having atrial fibrillation? Atrial fibrillation can also impair the filling dynamics of the heart when you have heart failure with preserved ejection fraction. That could be a reason to actually cardiovert the patient, that they're having so much symptomatology. And prolonged AFib can also cause low ejection fraction if it persists for quite a while. So a couple of interesting things, and also perform hepatojugular reflex as well.
Awesome. All right, I'll try to answer as many of those. So the skin is kind of normal pallor. There's no signs, no stigmatic chronic liver disease. The patient has a history of AFib, which may account for some of the irregular pulse, as some of the people in the chat are kind of pointing out. There's no appreciable hepatosplenomegaly as far as you can tell. The abdomen is just kind of like a little bit more full. There's no gallop. The heart percusses to normal order. And then the patient wasn't taking their apixaban. Yeah, that's correct, Deborah. Yeah, they haven't been taking it for the past 2 weeks. Conjunctiva are normal. There's no signs of icterus. There's no signs of liver dysfunction. So we get some basic investigations back in the emergency room, kind of just like the basic stuff here. So the hemoglobin, the CBC is pretty remarkable. They're a bit hyponatremic. They have a bit of an acute kidney injury, and they have mild transaminitis here. ECG is really just atrial fibrillation with no ST changes. Any other blood work that you'd want before we move on from blood work to some imaging tests?
No, actually, I was thinking about liver function disease and creatinine, but you have it here. So I am definitely situating myself in that. Whereas since this patient do not have liver stigmata, doesn't mean that the liver is not being affected. There is a mild transaminemia, and now we have fluid overload. Taking a step back, this patient has fluid overload, and there are three things that may cause fluid overload being generalized because this patient has this abdominal distension that might be due to fluid. So I would like to see if this patient doesn't have one, acute renal failure, acute cardiac failure, or has nephrotic syndrome. Now, those are like my new differential diagnosis here. And that will be basically what I want, what I will just start with. What do you think, Maddie?
Yeah, great thoughts, Yasmin. Some of the other labs I was thinking of would be a troponin and a BNP, especially, we were concerned about, cardiac process, congestive heart failure. So is there increased atrial strain? And also given the, I'm assuming an AKI, given that this is not their baseline, I would also want to get a UA. And I would also be interested in a bladder scan.
Awesome. I can give you all of those. Ask and you shall receive. So this patient's bilirubin's normal, their urinalysis is normal, their troponin's normal. Unfortunately, like some institutions that are real hospitals like London, we don't have BNP at our institution, which is interesting. So we're not going to get a BNP here, but I can see why people would want a BNP. Bladder scan is negative on either the bladder scan machine or on POCUS. There is TSH is normal. Yeah. Now, Preet, we will get to a POCUS. I promise you that. I promise you, I'm not going to leave the POCUS VMR without a POCUS. I'm trying to think of anything else that was asked there. Yeah, so I mean, it's like pretty unremarkable blood work. The patient has mild transaminitis, a bit of an AKI. They look fluid overloaded. We think it's heart failure. Their chest X-ray here, if somebody wants to have a quick look at that. Obviously limited quality underexposed AP, but within that limitation of this, would we say it's kind of dry or wet, if you had to say?
I would say wet.
Yeah, I'd agree. Wet, but not like florid pulmonary edema. There's no effusions. There's pretty crisp costophrenic angles. Maybe the hilum's a little bit impressive. So yeah, I agree. Like maybe a bit wet, but not the craziest thing you've ever seen.
Yeah, I also agree. There's the horizontal fissure on the right side has some fluid in there as well, which is tracking.
Exactly. Yeah, totally agree. That's a great point. So would anyone else like any other investigations now that we know it's a POCUS VMR? POCUS, oh my gosh, thank you. So I'm not going to give you all the POCUS. We talked about a lot of potential indications for POCUS for this patient. So we talked about bladder scan to rule out obstruction, which is awesome. So definitely, so the bladder scan is negative. We talked about ascites scan, which in a patient with abdominal distension and right heart failure, figuring out how much of this is ascites is a great indication. And so the ascites scan was actually negative. And then typically we would talk about heart and lungs, but unfortunately for you, this was not you doing the POCUS. This was the junior resident overnight that admitted the patient. And so none of your POCUS skills are available. So all they did was they looked at the heart and they looked at the IVC and they found this. And they said, you know what, that heart looks like the RV is dilated, similar to the baseline, the IVC is dilated. This all fits with our diagnosis of heart failure. So let's go from there. And so with that said, what would be your diagnosis and management for this patient? If you could write like maybe 6 orders for this patient, we're going to get an echo. We're going to do the rest of our diagnosis, but we think that this is heart failure. So what will we start for this patient?
Well, with heart failure, first of all, I think I would, depending on the stage, I remember that it's dependent on the stage. But I don't remember if it was preserved or
It was preserved. The EF was preserved on POCUS and a baseline HFpEF.
I'm not sure if I would start with ACE inhibitors. Obviously, I will be monitoring blood pressure, renal function, and potassium. But then again, I am not very sure. What do you think, Maddie?
Yeah, so in terms of diagnosis and management, so if we're concerned about heart failure, there's quite a lot of things. We want to monitor their I's and O's very strictly. We want to make sure that they are on the appropriate medications for that. So we'd want to go back and make sure, are they on angiotensin inhibition? So whether that's an Entresto or if that's like a mineralocorticoid receptor inhibition. Are they on a beta blocker? Are they on an SGLT2 inhibitor? So I would want to, oh, perfect. And they're also on some diuretics. So those would be, yeah, so I would want to make sure they're on those medications and strict I's and O's, and also get an echo to evaluate their ejection fraction right now. Those would be my initial thoughts.
Awesome. Excellent. So I see some questions here. It'll be a little bit hard for me to address all the questions in there. I will talk about TR in the context of some of the later case, but if there's anything missed, we can kind of talk about at the end. So totally. So this is a patient that we think has decompensated heart failure. We're going to put them on some sort of diuretic. We're going to start diuresing them. The diagnosis has kind of been dry, and so that's what we do. We start diuresing this patient with heart failure. We start thinking about adjuncts for different the heart failure management. And lo and behold, the weight for the patient starts coming down. But what happens? Creatinine starts going up. Now, who here has encountered this scenario when you're diuresing a patient with heart failure? I think probably all of us that manage heart failure. And inevitably on rounds, a medical student, resident, an attending is going to say, should they be intravascularly dry? And it's kind of like a question, but also a statement. And so I guess in this situation, what do we think? Is this patient intravascularly dry at this point? I mean, we've just said that the weight has come down from 90 kilos all the way down to 87 kilos, but then the creatinine's going up. We examine the patient because there's still pitting edema to the mid-thighs. So even though the patient's lost 3 or 4 kilos, they're still edematous and they're still on oxygen. So my question for you, and this is where POCUS is really, I think, going to have the most benefit for these patients with heart failure, is how do we figure out what we do next here? So some people in the chat are saying, keep going. Just Hassan, of course, is saying, keep going. Just creatinine bumps are irrelevant. I mean, many of us would be more worried about that. So what do we want to do here? And how would we approach this?
I think we can treat this as a renal failure in acute heart failure. So what I know is furosemide, and start with a bolus and then like keep it on a continuous infusion. But then again, I don't know if I will take off the other ones. And like if my patient keeps like he has a refractory EHF, I will think of like putting them on dopamine or something like that. But that will be my first choice, furosemide.
Yeah. So just to summarize, so you think that this patient still has cardiorenal syndrome? We've diuresed them, they've lost weight there, but because they still have peripheral edema, they're still overloaded. So we should keep going regardless of the creatinine. Just to summarize.
Now I'm very nervous to say something, because what if I make this patient worse?
Exactly, but those are the thoughts that cross all of our minds when we're managing these patients. That's the reality of managing these. And somebody's going to say, well, one's if the creatinine goes up to 170, 200, at that point, are you still going to keep diuresing? Could we do both? Could we give it and take it, give fluids and Lasix? Yeah, there's probably problems with that. Some people are saying, let's just keep going. Some people are saying stop. So clearly there's uncertainty here. Does anyone else want to add anything here?
I would repocus just to see and compare the images to what you had initially. Because if you still have IVC, I'm thinking like we're being lured in. The narrative of the case is just screaming out congestive heart failure with preserved ejection fraction. But I think at this juncture, you have to start entertaining other diagnoses, like the diagnosis Maddie and Yasmin had mentioned. And they early on had mentioned, what if there's an IVC issue like a thrombus? So we may need to take a look at that again. So measure the IVC and also then just to do another apical view, maybe parasternal short axis view as well.
Awesome. Yeah, I think this is a great time to add some focus to the case here. I have actually seen cases of IVC thrombus post hepatic transplant that have caused severe renal failure and congestion. So definitely a good thought. And so what I would kind of want to talk about for a minute or two here is multi-organ POCUS for volume assessment. And one of the challenges we face as clinicians for really any condition is this nebulous concept of volume status. What does that actually mean? Are we talking about filling pressure? Are we talking about forward function? I think what many people colloquially mean is, should we give this patient more diuretics or should we give them fluids? And POCUS can really help with that. And so there's two kind of areas that I'm going to talk about here. The first is kind of lung ultrasound, and the second is venous congestion ultrasound, including the IVC, hepatic vein, portal vein, and intrarenal veins. And the reason why we have to assess both is that our heart has two sides to it. It has the left heart, which when it congests goes into the lungs, creating pulmonary edema. But there's also the right heart, which when that congests goes into the IVC, into the intra-abdominal organs, and causes dysfunction. I see some comments about kind of IVC dimension. I can tell you that unfortunately it's not that simple. IVC dimension itself does not predict congestion. And we can talk more about that kind of at the end. But I think we need to definitely look at this. So when I apply a lung ultrasound to patients that I'm assessing for volume status, we use a 4-quadrant approach on the patient. So there's going to be 4 right-sided and then 4 left-sided views. And what we do is we'll take the ultrasound, and R1 is an anterior view, R2 is axillary, R3 is going to be kind of costophrenic angle, and R4 is this really posterior view. And when we think about left atrial pressure, which is a marker of left-sided congestion, we're really trying to classify things into A lines or B lines. So A lines are these horizontal artifacts that indicate a lack of fluid or pus filling the alveoli, whereas B lines are these vertical artifacts that extend down from the pleural line. They're these ring down artifacts, and they don't just mean fluid. They mean that there's something in the alveoli. That could be pus, that could be inflammation, that could be interstitial fibrosis in the setting of ILD, or in the right context could actually be pulmonary edema from elevated left atrial pressure. And if you see B lines, it does not mean that your patient is overloaded. You can get B lines from acute capillary muscle rupture causing elevated left atrial pressure. All a B line means is that there's something in the alveoli. But in the context here, the history of heart failure, perhaps that is congestion. And so this L1 is going to be anterior chest, kind of mid-clavicular line towards like the second intercostal space. And then R2, it would be more, so L1 would be on the left side, and then R2 would be more in the axilla. We can also look for pleurals, pleural effusion. So if we go down to the L3 or R3 or L4, R4, those more posterior views, we can look to see whether or not there's extra volume there. And we can see a pleural effusion with the lung floating in it. We can see the hemidiaphragm, the spine sign continuing up here. And so from a left-sided congestion perspective, lung ultrasound is very effective at quantifying it. And there's actually pretty good evidence that lung ultrasound-guided heart failure management may be superior to standardized care. That's the cluster heart failure randomized controlled trial that was done a few years ago. So this is definitely a well-established therapy and something I find very useful. But in our patient, what do we find here? So we scan all lung zones, and this is all we see. So does somebody want to interpret this and tell me what pattern they see and what the interpretation it is?
Yeah, I can go for it. So you've just outlined kind of the difference between A lines and B lines, and I kind of had my eye out for B lines to see if if there was pulmonary edema, those kind of more vertical lines from the pleura, but I don't see that. So I'm seeing more of these A lines.
Interesting. So, but our patient has heart failure. Like, how can they not have A lines or B lines? And so I think this kind of brings us to the next part of the case. And one of the great points that I think somebody made right at the beginning is there's a lot of different etiologies of heart failure to consider in this patient. Yes, of course, there's left heart failure, which causes congestion on the left, but there's also right heart failure. This could be from worsening pulmonary hypertension. It could be from ischemia. It could be from any etiology, but right heart failure itself will not cause B lines because it's not congesting into the lungs, it's congesting into our systemic organs. And one of those organs we really care about is the kidney. And if we think back to the beginning of our case, our patient had acute kidney injury. And so again, this fits a lot with kind of right heart failure. And so I'm going to kind of put this as a question and a comment. Is the IVC the beeline of the right heart? Kind of. So let's just kind of entertain this for a second. So if we have a patient with left heart failure with beelines, what does that tell us? Well, that tells us that the high pressure in the left atrium is being transmitted retrograde into the lungs, causing organ dysfunction. When we look at the IVC and when we look at hepatic vein, portal vein, and renal vein, which is what we're going to talk about, that reflects pathogenic right atrial pressure being transmitted into our organs in our abdomen, our liver, our bowel, our kidneys. And we know that elevated right atrial pressure, and particularly venous congestion, which is what we're going to talk about, is associated with organ dysfunction on the right side. It can be the brain, that can be the kidneys, that can be the bowel, cardiointestinal syndrome as it's described in heart failure. And so I think increasingly we're recognizing the importance of venous congestion for acutely ill patients. So when we talk about cardiorenal syndrome, which is really what we're talking about for our patient has acute kidney injury and right heart failure. There's kind of there's more, but there's kind of two really simple ways to thinking about it. One could be that there's low forward flow, low cardiac output, and that's cardiogenic shock. And the second is that high venous pressure or venous congestion is causing organ dysfunction. The cardiogenic shock makes a lot of sense. And I think that because we all think in terms of the Frank-Starling mechanism, which I'll have a bit later up, where there's that dropping off of cardiac output as we get more and more overloaded, I think we intuitively think that low cardiac output is responsible for acute kidney injury and heart failure. But most cases of cardiorenal syndrome are in fact a result of venous congestion or high venous pressures, because every organ has an organ perfusion pressure. That's your inflow pressure and your outflow pressure. And so if your MAP is 50 or 60, and then your venous pressure is 5, you have a really good perfusion pressure. But when that venous pressure goes from 5 to 10 to 15 to 20 in progressive congestion, you actually reduce the gradient by which you perfuse the kidney. And so we know that high venous pressure is associated with acute kidney injury. The challenge is, and this is the whole point behind using POCUS for this, the challenge is for a given patient in front of you, you do not know whether a venous pressure of 12 or 15 is pathogenic or not. For any of us on this call that are presumably healthy with normal cardiac function, that is pathogenic. But for somebody with chronic pulmonary hypertension, a CVP of 12 or 15 might be necessary to actually fill their right side and have adequate cardiac output. So the advantage to using POCUS and what we're going to talk about is we can measure congestion at the organ level. Instead of measuring it at the heart level centrally with the central venous pressure, we can measure it at the organ level. And that's through something like the venous congestion score. And so I think somebody in the chat mentioned that when we diurese people and the weight starts coming down, often we see a bump in creatinine. And the question is this actually acute kidney injury, or is this just an elevation in creatinine? And there's some evidence here, and this is kind of an interesting study that looked at increases of creatinine with initiation of diuretics. And this is going to sound weird, but actually increasing your creatinine when you start diuresing somebody to a modest amount is associated with better outcomes than decreasing your creatinine. It's totally counterintuitive. Some people imply that, or some people suggest that this is because you're actually hemoconcentrating people. Other people suggest that this is because if you're actually decreasing your creatinine in response to diuretics initially, the patient's so congested at the baseline that their overall prognosis is going to be worse. But this is different than how we think of it. So I don't think relying on creatinine as a marker to follow is a reliable thing. So we need to add something else. And that's where venous congestion ultrasound can be very, very valuable. Because we know that there's this interplay between the arterial system and the venous system. And this interplay happens at a bunch of different veins, the hepatic vein, portal veins, renal veins, and other organs. If you wanted to measure it in the brain, sure, it's just a bit harder to do so. But venous congestion, and if we could interrogate this, could help us solve that a little bit. So again, this is the Frank-Starling mechanism. Unfortunately, this is not why patients develop acute kidney injury in most cases of cardiorenal syndrome. It's mainly due to venous congestion. And so some ultrasound people decided that, hey, why don't we put this together into something called a VEXUS score? And I think going through the VEXUS score in detail is probably beyond the scope of this talk here. I just don't want to kind of bore people with it too much. But essentially, we can look at a combination of the inferior vena cava, hepatic vein, portal vein, and intrarenal veins and quantify it with a normal score being grade 0 or 1, and then grade 2 or 3 representing severe congestion. And when this was actually studied and derived in a cardiac surgical population, patients with severe congestion had significantly worse acute kidney injury than patients without congestion. And these were the kind of hazard ratios from the initial VEXAS score in a cardiac surgical population. But this has now been applied to multiple other populations, failure populations, critically ill patients. We've studied it in septic shock, and we have an ongoing international trial looking at this in septic shock. And I think what we're finding is that there's increasing evidence of this association between congestion and organ dysfunction. So what about our patient? So remember, let's just go back to our patient here and figure out what happened with them. So we diagnosed them with heart failure. They were overloaded. They had a dilated IVC. We started diuresing them. We put them on Lasix or furosemide or whatever your favorite diuretic is, and their weight started coming down. But with that, their creatinine started coming up as well. So somebody inevitably said, could this patient be over-diuresed? And so here we bring in our ultrasound to kind of interrogate the IVC because the lungs look clear. So if you just looked at the lungs, you'd say, yeah, this patient's over-diuresed. They have no pulmonary congestion. But thinking that our patient may have predominantly right heart failure, let's take a look here. So the IVC still very, very dilated. I totally agree. Don't worry too much about size or collapsibility. I don't think we'll have time to talk about a ton here, but again, we can keep this discussion going on Twitter. There's increasing evidence that arbitrary cutoffs of size or collapsibility have no role in assessing for venous congestion, and you can have patients with small collapsible IVCs that are still quite congested. This is something that we're describing. But when we look at the hepatic vein here, so a hepatic vein should have an atrial wave. So this is an A wave here that I'm highlighting. You can see the ECG, so atria right here. And then you should have a systolic wave that is going forward. So forward is below the baseline. This is reversal. So this is S wave reversal. Blood should not be flowing backwards during systole. Full stop. Yeah, this is the hepatic vein, Yasmin. So blood should be flowing forward during both systole and diastole. So here we have blood flowing backwards during systole, which is not normal. And then we have forward diastolic flow. So this is severe congestion. And the portal vein should have a smooth, continuous flow because veins have smooth, continuous flow when they're normal. This patient has significant pulsatility, 70% probably, representing severe congestion. And then at the kidney, so above the baseline here is an arterial tracing. Ignore it. Below the baseline is the venous tracing for these intrarenal veins. It should be this kind of like these monophasic patterns. It should be that level the entire cardiac cycle. And we're going to see one coming up as we continue to decongest the patient that shows that. It should be a smooth, continuous flow below the baseline because our veins drain organs during the entire cardiac cycle. That is healthy. That is physiologic. During patients with severe venous congestion, you get impaired drainage of our organs during predominantly systole because there's retrograde flow and the blood is going backwards from the right atrium, backwards from the right ventricle, into the IVC, into these organs and impairing their drainage. Think about it like a compartment syndrome of the leg. If the calf gets really tight from a myositis or an injury, the first thing that happens is you impair venous drainage. And then as you impair venous drainage, the pressure gets tighter, 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 and eventually you choke off the arterial system. The same thing happens in your kidney. Kidney's wrapped in a little sausage wrap called Gerota's fascia, and it has limited ability to swell. And as it gets more edematous, it has worsening kind of venous drainage, which eventually impairs the arterial flow, the perfusion, and you get acute kidney injury. So day 5, severe venous congestion. This hepatic vein, though, we keep diuresing them. So the IVC, maybe it's a little bit smaller, maybe not. But look at the hepatic vein here. So here is our A wave. This is going to be the best example. So our A wave is still retrograde. That's normal. But our S wave now is going forward. Previously, that was going backwards, which wasn't good. Now it's going forward, which is a little bit better. But it's still a lot less than this D wave here, or the diastolic flow. S should be bigger than D. So this is almost like reverse. Like this should be the S wave and this should be the D wave. But this is the S and this is the D. So that's still congested. The portal vein, there's still some pulsatility here. It's not as bad as before. Isn't like 70% pulsatile, but it's like 30-40% pulsatile, still mildly abnormal. And the kidney here, so again, ignore the stuff above the baseline, just look below the baseline here. So when we look at the Doppler, there's now this kind of biphasic pattern that for every one of these cardiac cycles, there's these two little humps. That's a little bit better than before, and I'll show you the previous one. So before there was just one hump, now there's two humps here, and I like the nephrosarca. Yeah, there is renal edema here, but that renal edema probably is continuing to improve with diuretics. So what do? We keep going. The creatinine's going up, but we keep going. So we keep going here, and now we look at the IVC, which is more mid-range. There's maybe a mild bit of collapsibility with easy respiration, and now we have a normal hepatic vein. So our atrial A wave is retrograde, that's normal. But then we have an anterograde or forward systolic wave that is greater than the diastolic. So we have returning to normal hepatic congestion. Ignore this little blip in the middle, that's a V wave, it's normal. Portal vein here, we can see starts getting a little bit more normal. There's kind of mild pulsatility here, but it's much more smooth and continuous. And then if we look at the renal vein here, notice how there's smooth, continuous flow below the baseline now. That is a normal venous drainage, because during our entire cardiac cycle, we should have venous drainage. So what does that look like for our patient? Well, the weight, we kept diuresing, so the weight kept going down, and the creatinine was going up, but then it started going down again as we started decongesting. And remember, creatinine reflects what happened 48 hours prior. It's not a real-time assessment of renal function. So we need real-time tools to apply to our patient to dictate diuretics now, and creatinine, unfortunately, isn't one of them. So it's kind of like driving, looking in the rearview mirror, if that makes sense. So that was a lot, and probably the least interactive VMR you've ever had. But with that said, any questions or comments that people want to make about the venous congestion Doppler?
Just like as a clarification point, like when we're doing the VEXs, we have to not only look at the dilation, not look at the collapsibility, but also the hepatic portal flow and the Doppler, right? Like it's a
Correct.
whole. Okay.
Correct.
Yeah, I think I got it. Thank you.
A normal venous. So Shreyas, this slide here at the bottom is a normal venous Doppler. Notice how there's flow all the way continuous below the baseline here. That's what a normal would look like. So, all right. So first of all, a couple things here. So venous congestion ultrasound is not simple. I know this is meant to be kind of the bread and butter POCUS. This is not bread and butter, but hopefully this shows the strides we're making to understanding physiology related to heart failure, and something we can strive to really master. There's tons of great resources online. NephroPOCUS has a website that has a ton of great resources. There's a VEXIS course that we run in Montreal every year. I'm happy to give grand rounds to people's institutions if that would be of interest to them on venous congestion and do similar talks on that. All part of kind of our mission to really understand rational fluid management. The second thing, somebody asked, well, what about tricuspid regurgitation? If you have tricuspid regurg, we know that the hepatic vein starts going backwards. We know that the renal vein starts becoming abnormal with tricuspid regurg. So is VEXIS valid in patients with tricuspid regurg? And I'll quote Philippe Rolla, who's one of the creators of the VEXIS score. The kidney does not care why it's congested. The kidney does not know that, oh, don't worry, this retrograde flow is due to tricuspid regurg, I'm going to ignore it. No, the kidney doesn't know that. The kidney is congested whether the kidney is congested. The only thing that matters is the treatment of the congestion, because congestion does not equal volume overload. There are many causes of congestion that are not related to volume status. So for example, pericardial effusions can cause congestion, right heart failure, pulmonary hypertension, pleural effusions, IVC thrombosis, intra-abdominal hypertension, ascites, patients who are volume overloaded. And so when you see a patient with congestion, it means that that organ is having impaired drainage, but it does not mean that that patient needs diuresis. They need an assessment and an understanding of what is causing their congestion and treatment of that. It could be pulmonary vasodilators, it could be inotropes, it could be diuresis, it could be a paracentesis, it could be a pigtail insertion, it could be pericardiocentesis, it could be a tricuspid clip in the setting of severe refractory TR. And so I think that this is one of the really challenging parts about VEXAS is people want VEXAS equals diuresis, but that's not the physiology behind it. VEXAS tells us what's happening at the organ level, but we still, as doctors and as clinical problem solvers, have to figure out the actual etiology of that congestion. And so with that, in this magical case, we diurese the patient to euvolemia, whatever that is. Their renal function improves back to their baseline, they're discharged home, and they have their heart doctor follow them up. So a couple take-home points before we go into some questions for a little bit. All right. POCUS can help guide diuresis in patients with heart failure. And hopefully we've kind of touched on that a bit here. Congestion should be assessed for both the left and the right heart. And this is one thing that I think with POCUS, we always want, well, what's the simple answer? Is it the JVP with ultrasound? Is it the IVC? Is it B-lines? Really, we need multi-organ Doppler because we have a left and a right side of the heart. There can be differential congestion between the hepatic vein and the renal vein that we need to look at depending on patients' intra-abdominal pressures. So I think simplistically, think about the left side, think about the right side when we're thinking about congestion. And then really venous congestion is the central part to the pathogenesis of cardiorenal syndrome and can be, and I would argue should be used to assess and titrate therapy. You know what, in the ICU, for example, we come on having not been the intensivist on for the past week, and we have patients in various stages of decongestion and diuresis, and it can be so incredibly difficult to figure out where you are. And so VEXAS at least gives you a starting point to say, all right, this patient still has congestion. Let's keep going for a little bit and ride this wave, even though their creatinine's going up a little bit. So it can be a bit of a north star with respect to diuresis. And so with that, I welcome any questions either here for the last few minutes that we have, but then also I think probably the easiest way to get a hold of me if you have questions, if you want to chat, whatever, is just message me on Twitter. I think most of the audience here is on Twitter by virtue of coming to Clinical Problem Solvers. If not, you can reach out to the Clinical Problem Solver team and they can pass along my email. But feel free to reach out to me at Ross Prager on Twitter. And I like talking about ultrasound and VEXAS and congestion and hemodynamics. So happy to share all the stuff we're doing. And thanks again for having me.
Oh, I just want to say, Ross, thank you for bringing such a useful case and showing something that's sort of nouveau in POCUS. I've been following this with nephro-POCUS, and I guess image acquisition is difficult for those that haven't yet tried POCUS, but I guess learning via course or maybe following one of the websites to know where to exactly put the probe to get the ideal Doppler measurements, that would help. But this is really impactful. Because this case, I mean, a lot of us would have just given up diuresis and stopped, thinking the patient is running dry. But this just shows the usefulness of this sort of like frontier POCUS sort of modality, which can be useful in trying to help our patients. So I really appreciate you coming on and spending an hour with us and teaching us about VEXAS scan.
Absolutely, my pleasure. Yeah. In terms of the acquisition is hard. And I think that's one of the bigger issues we're having within the POCUS community. How do we get this done? That said, it is possible to learn and to do high quality VEXAS scans even remotely. So as part of one of our studies that we're doing, Andromeda VEXAS, which is a sub-study of an RCT, Andromeda Shock 2, we're teaching centers around the world how to do VEXAS scans that have never done it before, that just have experience with POCUS. And we do that through essentially a couple hours of videos, a 1-hour webinar, and then a couple of remote quality assurance scans that we view remotely. And we're finding excellent data quality with those centers. So it certainly is something that if you're willing to put in 4, 6, 8 hours, play around with like a friend and scan their hepatic vein, portal vein, renal vein, follow the steps, I think it is manageable, but it's something that is harder than just, for example, imaging the IVC. So it takes a little bit of time and effort, but I think it's worth it. And it certainly has changed my practice and my career. So I would encourage everyone, particularly if you're in internal medicine, where I think this may even have the highest yield.
Yeah, amazing. Amazing. Thank you so much for all the discussion. I don't know if we have any questions in the chat. I think Navpreet, he asked like, after starting diuresis, when we can do reassess with POCUS?
Yeah, I think you have to look at what's like feasible versus what's like the feasibility versus the ideal world. So ideally, every 12 hours, every shift, you would assess the patient with sepsis, but we all have like 50 patients to care for and a million things on the go, and that's not going to happen. So when if I diagnose a patient with heart failure, that with a AKI, and I confirm that they're congested on ultrasound, I don't reassess their congestion status as I'm diagnosing them if they're improving. If their weight's going down, if their creatinine's going down, they're peeing, they feel better, they're starting to mobilize. I don't really think there's much benefit to repeating sepsis every day or every 2 days. Where I really use ultrasound is from that baseline. If something isn't going according to plan, the patient's creatinine starts going up, they're getting worse, not better. And I'm thinking, why? That's when I find ultrasound and injecting that time and effort really has the value. So at the beginning, when you're trying to kind of stratify which direction you're going, and then if something doesn't follow that illness script that we've developed for these patients, because we've all diarised 100,000 heart failure patients and seen them get better. If it's not following that illness script, that's when I start saying, well, do we have the right diagnosis? Have we not decongest them? Have we over-diuresed them? And that's where this can really help.
Amazing. Yeah, I want to say thank you for Maddie, Yasmin, and Robbie for being on board today with this session. And of course, Ross, that kindly accept my invite. So we really appreciate all your presentation. Everything that you teach us was like another level. And we are looking for more sessions because we are all POCUS enthusiasts.
Absolutely. Well, maybe we can do a VMR Vexus course. We can do that at some point for people that are interested.
Yeah, let's do it. We can. I will talk with you about it. So yeah, thank you everyone, and I hope to see you all tomorrow.
Take care.
Thank you.